Hi, today we'll be talking about a clinical approach to stridor. I'll be talking exactly that. I'm reiterating it again. We will not be talking about the multitudes of causes of stridor. We will not be talking about the investigations that you have to do. I think all of you can read that up from your standard textbooks, and there are multitudes of articles available. In this session, what we are going to be talking about is how do you identify a stridor and how do you identify the level at which the obstruction is causing the stridor. So what is stridor? Stridor is a harsh, usually high-pitched sound, usually inspiratory sound, and this is due to an obstruction of the upper airway. This is a monophonic sound. I'll repeat it again. This is a harsh, high-pitched, usually inspiratory, monophonic sound secondary to obstruction of upper airway. This obstruction results in oscillation of the narrowed airway, causing the sound that you know as stridor. How do you differentiate it from a wheeze? Wheeze is generally polyphonic and it is secondary to obstruction of lower airways. It's not upper airway, it is lower airways. What's the mechanism of stridor? Stridor is secondary to the Bernoulli's principle. Doesn't matter if you don't remember the physics, we'll recall it together. Normally, a gas at rest exerts pressure equally in all directions. Suppose if this gas is going to go in one particular direction. So what happens? The pressure on the lateral aspects reduces. This is the pressure that is supposed to keep the airways wall open. If this pressure is going to reduce, then you have the possibility of walls collapsing on itself. Imagine in an infant whose walls are already going to be slightly floppier compared to that of the older child. So they are more prone to have this airway collapse. Imagine in a child who is having a narrowing in the airway, secondary to whatever reason. So this drop in pressure that is happening is going to be more beyond this obstruction. Hence, this drop in lateral pressure, which will not be able to hold the flexible airway open, will cause the collapse of narrowed airway beyond the point of obstruction, and this results in a stridor. The anatomy of it, almost all of us know. The airway starts from the nose and ends in the alveoli. So from nose, then you have your tongue, you have your nasopharynx, your oropharynx, then lower down you come to the supraglottis, glottis, subglottis, trachea. In trachea again you have an extrathoracic trachea, intrathoracic trachea, you have larger bronchi, then smaller bronchi and bronchioles, and so on and so forth. We are more worried about the supraglottis to tracheal region. If there is a problem above the supraglottis, somewhere between the nasopharynx to the supraglottis, if there is an obstruction, what you generally have is a low pitched sound that is called as a stridor if the child is awake. If the child is asleep, you call it as a snoring. Suppose there is an obstruction below the intrathoracic trachea in the smaller bronchi, then you call it as a wheeze. Wheeze is polyphonic and it is usually expiratory. So in between supraglottis to intrathoracic trachea, you have a problem, then you end up with a stridor. So how do you know which has caused what? So let's see with some examples, history wise examples or examination wise examples as to how to differentiate them. One is age of onset. If a newborn is going to present with a stridor, never think of laryngomalacia first. Think of other causes. Think of vocal cord paralysis. Think of a laryngeal web or a vascular ring. Because any malacia, be it a laryngomalacia or a tracheomalacia, starts developing later. It starts beyond 2 to 3 weeks, usually around 4 to 6 weeks. Older children, it's always acquired causes to be thought first, especially if the patient is presenting acutely. If the patient is presenting to you chronically, it could be anything. If the stridor is presenting to you acutely, then think of acute causes. Foreign body always should be thought of. Never discount foreign body even in an infant, especially if the infant has an older brother or a sister. Infection. The classical infection that you know is croup or acute laryngotracheobronchitis, which presents to you with stridor. Anaphylaxis, especially if the patient has a known food allergy, is having an urticarial rash, a facial swelling, angioedema like presentation. Airway burns. Airway burns is especially common in the current era where we have microwaved food, microwaved water. Okay, so there will be pockets of hot liquid which can give rise to airway burns when the child is trying to swallow that hot fluid inadvertently. Chronic presentation of a stridor, everything else you will have to think of. Stridor, if it is going to be more in supine position, tracheolaryngomalacias, a big tongue which is falling back and obstructing the airway has to be thought of. If the stridor is associated with voice strain, if the stridor is going to become worse while the child cries, then you can think of laryngomalacia, you can think of a subglottic problem. Example, a subglottic hemangioma especially. If the stridor is associated with voice loss or a hoarse voice, then think of a vocal cord level problem. Okay. The one thing that I would like to point out here is the child may have a normal voice if the child is having a bilateral vocal cord paralysis despite having a stridor, because the vocal cords are going to be approximated with each other. If it is going to be unilateral vocal cord paralysis, child will have a hoarse voice, child will have a stridor plus a risk of aspiration. If the stridor is worse with feeding or it is associated with feeding difficulty, think of a esophageal problem that is associated or an extrinsic compression that's causing both tracheal and esophageal compression, like a vascular ring that is causing obstruction, a tracheoesophageal fistula, central causes which can cause both a feeding difficulty as well as a breathing difficulty. Extrinsic compression at or above the larynx, child can present with extension of neck. And remember, intrathoracic tracheal problem will give rise to an expiratory stridor, whereas an extrathoracic tracheal problem will give rise to an inspiratory stridor. I will tell about the mechanism in just a moment. If the stridor is associated with cough, if it is a barking type, think of croup. If it is a brassy type, think about a problem in trachea. Always remember, cough means airway problem. Okay? If there is no cough, it's not an airway problem. If the stridor is associated with drooling, muffled cry, then it's a supraglottic problem. A classical example of hot potato voice, drooling, sick child, muffled voice, all of this is epiglottitis, a retropharyngeal abscess. If the stridor is associated with urticaria, swelling of face and lips, then think of angioneurotic edema. These are some of the examples where you can elicit cause from just history and examination alone. For example, if say the child is having this worsening of stridor when the child is crying, you are thinking of a subglottic hemangioma. What would support your diagnosis is you finding a hemangioma in the skin, especially if it is a segmental hemangioma in the mandibular region or in the beard region. If you find a hemangioma, there is a high likely possibility that the child is having a subglottic hemangioma too. So now what I told earlier, the extrathoracic trachea having inspiratory stridor. So here you have the obstruction in the extrathoracic region. During expiration, what happens? It is going to be a positive pressure, correct? Normal spontaneous respiration is negative pressure during inspiration and positive pressure during expiration. So during expiration, when the child is exhaling out, so there is going to be positive pressure. This positive pressure is enough to open up the airway. In other words, this is a dynamic extrathoracic airway obstruction. So if the obstruction is dynamic in the extrathoracic airway, it's going to be a stridor during inspiration alone. Why during inspiration? Inspiration is a negative pressure, correct? So if there is a negative pressure, the tracheal pressure falls compared to that of the surrounding pressure. So this surrounding pressure will cause collapse of the airway. So that is why you have a stridor that is worsening during inspiration rather than expiration. The reverse happens during a intrathoracic airway obstruction. See, the trachea is going to be surrounded by your pleura. So pleural pressure increases during expiration, correct? So this increased pleural pressure will compress upon the airway during expiration. Hence, your intrathoracic airway obstruction, which is dynamic, will present as an expiratory stridor rather than an inspiratory stridor. Now the question comes, what if it is a fixed obstruction? If it is a fixed obstruction anywhere in the airway, it's a biphasic stridor. So to put everything together in small nuggets, stridor and respiration combo, if the patient is having an inspiratory stridor, problem is in extrathoracic region above glottis. If it's an expiratory stridor, it's an intrathoracic obstruction. If it's a biphasic stridor, think of fixed or critical obstruction anywhere in the airway. You can think of an obstruction between glottis and subglottis region. Stridor and voice combination. If the patient is having a hoarse voice or completely aphonic, problem is in glottis. If it's a muffled voice or a hot potato voice, problem is in supraglottis region. If the voice is normal or stridor is worse with strain, then you should think of a subglottis problem. This is from American Academy of Family Physicians, where they have given a flowchart like presentation. This is basically a compilation of what we discussed so far. If the stridor is inspiratory associated with snoring, then it is nasopharyngeal region. If it is associated with a muffled voice, see if the child is febrile or afebrile. If it's afebrile, if the child is afebrile, then think of a adenotonsillar level problem. If it's associated with fever, muffled voice, supraglottis problem, which is acute, which is infectious, think of tonsillitis, epiglottitis and abscess. If the stridor is inspiratory, associated with voice change and hoarseness, laryngeal problem. If the child is febrile, think of epiglottitis croup. If the child is afebrile, then some other mass. Biphasic stridor, think of foreign body if it is acute. If it is chronic, some other mass or compression. So that's all about stridor. One extra point you can note down is laryngomalacia is usually an inspiratory stridor, whereas tracheomalacia, the cartilage problem happens in the intrathoracic trachea, hence it's an expiratory stridor. So that's it. I hope we have covered stridor to some extent. I would not say everything, but this is how you approach a child clinically when the child is going to present to you with stridor for anatomical localization. You can refer up your books for the causes and work up individually once you narrow down the diagnosis. Thank you guys for listening patiently. Bye bye, take care and all the best.